molecular radiotherapy, this is the delivery of radiation by giving a patient a radioactive substance, either to swallow or as an injection. So it's giving the radiation internally. And it takes advantage of there being some sort of target in the cancer cell that will specifically take up the radiation. So the most well understood, perhaps, example of that is using radioactive iodine in thyroid cancer. And that's a really excellent targeted treatment in thyroid cancer because thyroid cells are virtually the only cell type in the body that has a pump that pumps iodine into them. So if we give radioactive iodine, it's almost entirely selectively taken up into thyroid or thyroid cancer cells and delivers high doses of radiation, as I've said earlier. So radioiodine we've been using, it's actually the 80th anniversary this year of the first patient being treated with radioiodine, so that's a very long-standing treatment. Since then, there have been other developments in molecular radiotherapy, but they've tended to be in fairly rare tumour subtypes. So, for example, there are some treatments that are very useful for patients with neuroendocrine tumours, but again, they're fairly rare tumours. So it's been a pretty niche area. What has changed significantly this year is there's a major study was presented at ASCO, at the plenary session of ASCO, with a novel molecular radiotherapy treatment for treating prostate cancer, which has shown significant benefit for that group of patients. Now, prostate cancer is clearly much more common than thyroid or neuroendocrine tumours. So this opens the sort of the treatment up to a much wider group of patients. And indeed, we know there are many other trials of novel molecular radiotherapy agents in other sorts of more common cancers that are coming through. And we are expecting to see much more of this in the coming years. So it's very much a growth area. So that's one of the reasons why we wanted to highlight these developments at the festival. So the other issue with molecular radiotherapy is getting better at personalising the treatment. So many of these treatments at the moment, the common practice is to just give the same amount of radiation to every patient that we treat. But we know there is good evidence that the amount of the activity of the radiation that we administer to a patient, even if that's the same for every patient, we deliver very different doses of radiation to the actual target, to the tumour. So that's been shown in thyroid cancer that if we give a standard empirical activity of radiation, the absorbed dose delivered to the tumours ranges to anything between just 2 or 3 gray and 300 gray. And we know from principles of general radiotherapy delivery that the response to the treatment is much more likely to be related to the absorbed dose that we deliver in gray than to an empirical activity that we've given to the patient. So it's really important that we understand better what doses we've delivered to the tumours. Now, until quite recently, that's been quite tricky. It's not as easy as with external beam radiotherapy calculating those doses, but we do now have the scanning equipment and the software available to be able to measure absorbed dose. And so one of the things we want to promote is looking more to doing this dosimetry work so that we can know what doses have been delivered and therefore potentially better personalise the treatment for individual patients. So this is one of the important outcomes, I think, from the SELIMETRY trial, that we did undertake this dosimetry and show that it is possible to predict and to measure and to predict the absorbed doses to deliver. And I think this is going to be important to make sure that we get the most benefit out of these novel molecular radiotherapies.